Matthew sir will also join.
Matthew is traveling, so I
Okay,
think
okay,
he's
okay,
not
fine,
in a position to
fine,
join.
fine,
I think
fine.
one more person, Dr. Dattaraj Swarkar is
Sir, Dattaraj was in OT. I'll quick check where is he now.
right. Okay.
He had a. I'll call him, sir.
Uh, we'll start at
He
4,
looks
Dr.
busy in
Jitin.
OT, sir. We can start as per our schedule, sir.
Yes, it's 3:59. We'll start at 4.
Yeah.
Good evening, everyone. On behalf of NSI and NSI Webinar Committee, myself, Dr. Kodishwaran and Dr. Matthew Abraham, I welcome you all for this NSI 75th year celebration webinar series. This time we are going to take a interesting topic of brachial plexus and peripheral nerve injuries, and also we are coordinating with this joint webinar with Indian Society of Peripheral Nerve Surgeries. So today the main coordinator of this meeting is Dr. Jitin Bajaj. Professor of Neurosurgery, NSCB Medical College, Jabalpur. And the coordinator will be Dr. Surya Gaur, Assistant Professor Neurosurgery, AIMS, Delhi. I welcome Dr. Jitin to take over and introduce the speakers.
Thank you very much. Firstly, I should introduce Professor Kodishwaran sir, although he doesn't need any introduction. He is professor and head of department at neurosurgery at Kilpauk Medical College, Chennai. And he's extremely academic and he's running the NSI Board of Education very well. So we are extremely thankful to Neurological Society of India as well as Indian Society of Peripheral Nerve Surgery. So we are also thankful to speakers and all delegates who are attending this webinar. So can you see my slides?
Yes.
Are you seeing my slides?
Yes.
So our first speaker is Dr. Surya Gaur. Dr. Surya Gaur. Dr. Priyadarshi Dikshit is not available due to due to a medical emergency in the family. So we are thankful to Dr. Surya for giving this, for agreeing to give this webinar in a short notice. So Dr. Surya Gaur is currently Assistant Professor Neurosurgery at Jai Prakash Narayan Trauma Center, AIMS, New Delhi. He's an EC member of ISPNS and he has special interest in spine and peripheral nerve surgery. Thankful to you. Second speaker will be Professor Dr. Amit Thapa. He's professor and head at neurosurgery at Kathmandu Medical College. He is president-elect of Nepali Society of Neurosurgeon, vice president of Nepal Epilepsy Society, advisor to World Federation Neurosurgical Society's Peripheral Nerve Committee, WFNS Neurotraumatology, EC member of ACNS, EC member of WESS, and a member of Education Committee at AASNS. He has numerous publications in international and national high-impact journals. He is also editor-in-chief of Nepal Journal of Neuroscience. He has special interest in peripheral nerve surgery, minimally invasive brain endoscopic surgeries, and robotic neurosurgical procedures. So we are thankful to him. Professor Sumit Sinha is our president of ISPNS. He's also honorary treasurer of Neurological Society of India, honorary secretary of Neuroendoscopic Society of India, president of Neurotrauma Society of India, president Indian Society of Peripheral Nerve Surgery, and EC member Skull-Based Surgery Society of India, and member of WFNS PNS committee. Thankful to you, sir. And Dr. Chandan B. Mohanty, he's associate professor at Bombay Hospital, Mumbai, and honorary consultant at BJ Wadia Children's Hospital, Mumbai. He is a EC member of WFNS Peripheral Nerve Committee, EC member of ACNS Peripheral Nerve, and education officer of AO Spine Indian Subcontinent. So again, thankful to all the speakers. I request Kodishwaran sir to have an introduction of panelists.
We have two panelists today. One is Dr. Rajiv Sharma. He has graduated from NIMANS Bangalore and he has multiple advanced training in cerebrovascular surgery, spine deformity, treasurer ISPNS and secretary ISPNS. The next panelist, Dr. Dattaraj Swarkar, professor of neurosurgery, AIMS Delhi. I welcome these two panelists to join us for this wonderful meeting. Now we will start the
Dr. Surya, you can start.
Yes. Good evening, all. Are you able to see my slides? And
Yeah,
am I audible?
it's visible. Yeah, you are audible, loud and clear.
Thank you, Dr. Kodishwaran and Dr. Jitin. And thank you, NSI and ISPNS, for this opportunity. So I would like to focus mainly on the clinical examination and, if time permits, on the electrophysiological evaluation of adult brachioplexus injuries. So the goal of clinical evaluation of brachioplexus injury is to identify the extent of injury, whether it is partial or complete, and to identify the level of injury, whether it is a root injury or a distal injury involving the trunk division, cord, and branches, and if there is any time-related change. So the entire goal of clinical evaluation is based on this triad. So the clinical evaluation should ideally be done as soon as feasible to mainly get a baseline which can be compared later on, and ideally should be performed by the same examiner to avoid inter-observer variation. The important factors that needs to be assessed is the age of the patient, because as you're all aware, older age patients have a poorer prognosis. And regarding the history, the duration since the injury, and what was the mode of injury, and whether what kind of energy of trauma was sustained at the time of injury, whether it was a high velocity injury, and if there was any recovery over time, and if there is associated pain and social factors. So the clinical examination is mainly the examination of the sensory component, motor component, and to look for trophic changes. And also not to forget, we should also look for associated injuries, that is head injury or spinal cord injury, associated rib fractures, clavicular scapular fractures, and vascular injury. The important anatomical consideration while evaluating brachial plexus is, so there is a possibility of a prefixed or a postfixed brachial plexus, which can have a different presentation than a routine upper brachial plexus injury or a lower brachial plexus injury. So this should be kept in mind. So brachial plexus injury, it can occur in isolation or can be accompanied by other severe injuries. So a patient may, with a concomitant head injury, may have a hidden brachial plexus injury that should be noted. And a high index of suspicion should be kept when any patient presents with injury of the shoulder girdle, or if there is any fracture of the first rib, or if there is any vascular injury of the axillary artery. So spinal cord injury with brachial plexus injury, how common is it? Although rare, we have routinely seen patients with such presentation, especially in patients who are unconscious. So one can suspect if a concomitant spinal cord injury if the patient has an affected lower limb on the same side. And the gamut of spinal cord injuries can be like the entire spectrum can be seen as described here. And also in patients with head injury, they can have associated brachial plexus injury. So that should be kept in mind. And patients may have traumatic torticollis due to severe paraspinal muscle denervation, and as described earlier, associated bony injuries. So there is an incidence of around 15 to 25% of major vascular injury in brachial plexus injury, and we should maintain a high index of suspicion even in patients who have normal pulses. That is, around 10% of patients with normal pulses may have associated vascular injury. We must all be aware of hard signs of vascular injury in acute brachial plexus injury, that is pulselessness, expanding hematoma, obvious acute bleeding, and pallor, which tells us that there is a vascular injury along with brachial plexus. So coming to examination of vascular system, we should always palpate for the radial ulnar pulse, look for capillary refill, and any presence of bruit or thrill. Then coming to the sensory examination, we are all aware that sensory examination is subjective, but a comprehensive sensory examination along with motor examination, it identifies the affected nerve roots, and it also helps in evaluation of recovery over time. So a systematic and a sequential sensory examination should be performed, and we can utilize certain data sheets like MERL-D, OBEAN, or Mayo Clinic brachial plexus records. So the various modalities that can be assessed is, we are all aware of the light touch, which can be done with the use of an examiner finger or a cotton whisk, and or a vibration threshold with the help of a tuning fork, and cutaneous pressure threshold with the use of a monofilament, and 2-point discrimination, that is static or dynamic, with the use of a discriminator. And also it is important to assess the pain in these patients, and it is always compared to the normal contralateral limb. Also to be noted is the several types of sensory symptoms that can be seen, that is paresthesia, hyperesthesia, anesthesia, and dysesthesia, and it should be noted. So where are these modalities tested? So there are typical dermatomes described as in this pictorial representation. So C5 is we are all aware over the deltoid area. C6 is the lateral forearm and the thumb. C7 is a middle finger. C8 is a little finger, and T1 is around the medial aspect of arm. So the dermatomes vary on the front and the back. But there is a lot of overlapping of peripheral nerve distributions distally. So in order to identify a specific nerve injury, there's something called as autonomous zones. Like radial nerve is typically examined in the anatomicus nerve box, whereas medial nerve is examined over the ring and index and the middle finger, whereas the ulnar nerve is examined over the little finger, and the axillary nerve typically over the regimental patchy. And coming to deafferentation pain, it is important to assess this, grade this pain with the help of a visual analog score. And it is more commonly seen in avulsion injuries, that is preganglionic injuries. And a questionnaire can be used to grade patients with deafferentation pain. Important examination that needs to be done in brachial plexus injury is Tinel sign. So it correlates with the regeneration of axon, and it can tell the pattern of injury and predict clinical course. Tinel sign is absent in preganglionic injuries. It is important to note that it's absent in preganglionic injuries and also in patients with conduction block or neuropraxia. Although it is present in patients with a postganglionic axonotmesis or neurotomesis. So a light tap over the posterior triangle may show a Tinel sign over corresponding area depending on the nerve that is affected. And there has been certain grading systems described for grading the recovery of the sensory system. This grading by Hyatt and Seddon based on the recovery of static and dynamic 2-point discrimination. So this is the grading system that can be used while evaluating patients with brachial injury. So coming to motor examination, so there are 3 components that needs to be examined. That is observation for any muscle atrophy, manual motor testing, but the most important thing which we usually forget is the range of motion, that is both active and passive. So all these are important, and the premise for examining motor muscles is to be aware of certain trick movements that patients develop over time, and it is important to isolate the muscle to be tested. So there are certain data sheets that can be used for grading this muscle. So this is one such data sheet devised by Merle Diobin and another by Mayo Clinic. So coming to certain features which can tell us about presence of preganglionic injuries. So presence of Horner syndrome, that is myotic pupil, can help us in identifying a T1 preganglionic injury. We must always be aware of inspectory finder, that is presence of bruising, trophic changes. So this should not be missed. So the patient should ideally be examined fully undressed till the hips, and yeah. So you can see here there is some drooping of some shoulder. There is some winging of scapula. So coming to examination of isolated muscles. So here you can see there is atrophy of the trapezius muscle, and in this patient he has a severe torticollis due to severe paraspinal muscle injury. So the way to examine trapezius is to ask the patient to elevate the shoulder while you're standing from the back. Then how do you grade these muscles? We are all aware of the MRC grading, that is grade 0 to grade 5. Although we are all aware of the commonly used description, but you must be aware of the original description that was used. Here, as you can see, M1 denotes only contraction in proximal muscles. M2 denotes only contraction in the in the distal muscles. So, but there is some limitation. It has been found in some studies that even patients with grade 5 power have less than a normal strength when compared to the other side. And in order to make the grading more precise, you must always look for active, movement in active and in passive motion. So there are certain myotomes that can be examined. So for C5, typically we look for abduction of the shoulder. C6, we usually look for the elbow flexion. C7, we look for elbow extension. C8, we look for finger flexion. And for T1, we examine for finger adduction or abduction. So this is a typical examination for serratus anterior. Although in patients with global brachial plexus injury where they cannot push against the wall, ideally you should insinuate your finger along the inferior angle of the scapula and ask the patient to push the shoulder against resistance. So if there is winking, you're able to insinuate the finger between the middle of the border of the scapula and this back. So this is how we examine for rhomboids, where the patient is asked to press against the back, and we palpate along the medial aspect of the scapula. We are all aware how the initial 15 degree of abduction is uh, contributed by the suprascapular nerve. So infraspinatus is a external rotator of the shoulder, and here this is how we examine where the arm is adducted, and we ask the patient to externally rotate the elbow in a flex position against resistance. So, and these are certain. So pectoralis is examined by palpating the muscle while asking the patient to adduct against resistance, the sternal and clavicular head. So we examine the latissimus by a cuff test. We ask the patient to cuff and hold along the inferior aspect of scapula. So deltoid helps in abduction. So anterior and middle can be examined by asking to abduct against resistance. And the posterior third of the deltoid is examined this way where the patient is asked to bend forward and to abduct. So biceps is typically examined in a semi-pronated flexed elbow, where the patient is asked to is the biceps palpated and patient is asked to flex against resistance. And triceps is examined in a abducted position where the patient is asked to abduct his elbow overhead. So this is how the triceps is examined. So brachioradialis is examined where the patient is asked to flex the elbow and you can palpate the brachioradialis tendon at 90 degree flexion. So these are the various muscles that can be examined, that is flexor carpi radialis, ulnaris, profundus, which flexes the distal interphalangeal joint, and FDS, which flexes the proximal interphalangeal joint. Then examining the palmaris longus. So this has a role in in examining peripheral nerve injuries, flexor pollicis longus. So yeah, so lumbricals, dorsal interosseous, which helps in abduction of the finger, whereas palmar interosseous is adductor. So these are the various deep end reflexes that can be examined. That is C5, 6, 7 have concomitant reflexes, whereas C8 and T1 does not have a reflex. So what suggests that patient may have a root avulsion injury? So a presence of a Horner's sign and as described absence of Tinel's sign. If the mechanism of injury was by when patient head shifted away from the site of injury, where there is severe atrophy of paraspinal muscles, when there is associated winging of scapula, when patient has severe deafferentation pain, elevated hemidiaphragm due to pharyngeal palsy. So all these findings are suggestive. So presence of these does not mean that patient may have preganglionic injury all the time. It is only suggestive, but it is not definitive. That is to be noted. So coming to, do I have time?
Yeah,
You
you
can
can
continue. You can
continue.
continue.
yes.
Yeah, thank you. So these slides were given by Dr. Priyadarshi. I'm thankful to him. So electrophysiology, it complements your clinical examination and radiological evaluation, and it confirms the injury when the examination is limited, and it helps in localizing the level of the lesion, and it helps in differentiating axonal loss versus conduction block, and it can differentiate avulsion, rupture, or a peripheral nerve lesion. It also helps in prognostication. So it also helps in deciding what kind of surgery needs to be performed and whether observation is required or early exploration is warranted. And yeah. So a typical electrophysiological study includes a motor nerve conduction study, a sensory nerve conduction study, F waves. We perform a needle EMG of the muscles and paraspinal muscle EMG, and we always compare it with the contralateral side. So typically, ideal timeline for performing EMG is around 6 to 12 weeks. It is best for determining the severity of injury, and also that is a time when we can identify early reinnervation. So the nerve conduction study, it tests the fast conducting myelinative fibers, where we assess the amplitude, which determines the axonal integrity, the and latency and velocity, which determines the myelin integrity. Whereas the needle EMG, it detects whether there is any denervation and any reinnervation with time, and what is the chronicity. So typically in neuropraxia, there is conduction block and there is decreased action potential across the lesion, but distally it is normal. And since it is only a neuropraxia, there is no denervation seen in EMG. Whereas in axonatomosis or neurotomosis, there is decreased CMAP amplitude, but along with that, you see fibrillations and positive sharp waves, which are indicative of denervation in EMG. So, in patients with there's another aspect which needs to be seen is for the SNAP. Normally, there is decreased amplitude in case of post-ganglionic sensory nerve fiber, but in a patient with clinical sensory loss, but with a normal SNAP, it indicates that there is a preganglionic lesion. So this is the differentiation between preganglionic and post-ganglionic injuries. In a preganglionic injury, as described, the snap is normal, whereas in postganglionic it is reduced. And typically, the paraspinal muscles are denervated in preganglionic injury, whereas it is normal in postganglionic injury. So, this is the importance of performing paraspinal EMG, where so denervation here, it denotes that it is a preganglionic injury. And these are the muscles sampled typically for the various nerve roots. So EMG helps in identifying denervation and also renervation. And these are the various signs of denervation, that is presence of fibrillation potential, positive sharp waves, fasciculations. And presence of this, it denotes that there is active denervation, and it usually appears after 3 weeks. So there are certain signs which is beyond scope of this webinar, that presence of motor unit potential, recruitment, which denotes that there is a reinnervation. So these are the various muscles that are sampled depending on the root involved. So C5 supplies deltoid biceps supraspinatus. So these are the various muscles that are typically sampled while performing NCS and EMG. So this is the typical involvement that is seen in upper trunk, middle trunk, and lower trunk involvement, and the various sensory nerves that can be involved in various peripheral nerve injuries and isolated nerve injuries. So these are typical muscles and sensory involvement that can be seen. So coming to conclude the presentation, it is important the premise of clinical examination is to identify the extent of injury, level of injury, and to look for any time-related change. So we must be aware of associated injuries and always examine for recovery. and examine in particular dermatomes and myotomes, and always be aware of findings associative of preganglionic injury. Thank you.
Thank you, Dr. Surya. Thank you very much. It was a very nice webinar, nice presentation. So, Kodishwaran sir, should we take the questions at the end?
The end.
Okay.
We'll take all questions at the end.
So now we invite Professor Dr. Amit Thapa to start his presentation.
Can you see my slides here?
Yes, yes.
Dr. Amit, we can see.
No.
We can see your picture, not your slides.
Yeah, it
Yeah.
should be visible now. Okay.
Yeah.
So before I start, let me extend my warm greetings to all of you. And I'm very much thankful to both NSI and Indian Society of Peripheral Nerve Surgery for having me here. It is so wonderful to see excellent work being done at your place, and a lot of my mentors and the seniors, as well as the future neurosurgeons here, are so much interested in peripheral nerve injuries and repair that it's very, very encouraging to see the good work and which is happening. And the recent event at All Indian Institute of Medical Sciences, New Delhi, of ISP in Con 2026 is still fresh in our mind. So this is some glimpses of my beautiful country. If you have not visited or you have visited once, so you should always invite it to visit us. So there is no significant disclosure to my presentation here. So the outline of my talk would be to discuss about the challenges, what happens after the trauma, types and classification management protocol, when to do what, prognosis, and I will be including some clinical weakness in between. So this was some years back. I presented an editorial and why we should not wait on the basis of an expectant management, particularly in the peripheral nerve injuries. And the reason had been frequently evident because in the rat model, as well as in many of the human models and clinical cases which you have seen, the end receptors starts getting atrophied when there is no innervation, and subsequently the muscles get atrophied. So it has been seen invariably that the result of any reinnervation procedure after 12 months is very, very poor. So we like to act on these patients as soon as possible, preferably between 3 to 6 months, so that we have that good window of reinnervation as soon as possible. In our place in the Indian subcontinent, the challenge is very, very huge as compared to the global scenario, where the estimated incidence of mixed injury, both traumatic and metabolic, had been 53 per 1,000. In India and Nepal, we have both road traffic accident as well as conditions like leprosy and diabetes also causing a lot of incidence of neuropathies. And we have seen that most of these injuries are occurring much more on the upper limb as compared to the lower limb. And as the previous speaker also rightly said, that it is a diagnosis of suspicion. So if you have a very red flag sign, we should always look for it intentionally. So because peripheral nerve surgeries can be easily missed, particularly if in case associated with the brain injury, or when the patient has a bony fractures and it is hidden underneath the cast. So a brief about the peripheral nerve. We all know that the myelinated nerves are covered by the myelin sheath, which actually wraps it into different sheets of myelin, and there are nodes of Ranvier, which are basically exposed portions, and this actually helps us saltatory conduction for the fast conduction of the electrical signals across it. So these nerves are actually bundled together inside a perineurium sheath. So endoneurium is the inner core, outside is a perineurium, and most of the blood supply actually lies above the perineurium, and that's why we have seen that any injury above outside the perineurium is bound to cause much more of a scarring. And epineurium is the structure which actually bundles it together into a named structure of a nerve. So whenever the injury occurs in a very simple format, if you understand, so there will be a proximal stump and a distal stump. And this degeneration, which starts within 24 hours, particularly the distal fragment. And this is a beauty of the peripheral nerve as compared to the central nervous system, because in the peripheral nervous system, within 10 days, the myelin sheath breaks up into the lipid droplets around axons, and the macrophage plays a major role in eating away this myelin. And that's why the ground is set for a fresh new axonal growth cone to develop, and within 3 months, the Schwann cells proliferate. So there is a transition of these Schwann cells from a transmitting cell into a proliferating cells, and these Schwann cells actually lined up together underneath an intact basal lamina through which the exons can actually regenerate. So this usually happens if in case the coverings are intact and the gap between the defect is not so much. Otherwise, it just starts developing axonal or collateral sprouts through which this particular regeneration occurs. Now, there are various ways through which this injuries has been classified, but the most easy way which can be used to interpret these types of different injuries has been propounded by Mida's group, in which they have actually identified three different sources of injury. It can be a high energy one, which can be classified as avulsion, transaction, stretch, or contusions. And accordingly, there will be sharp cut injuries or blunt injuries or neuroma and continuity. Low energy injuries are basically entrapment, compartment, and injection injuries, and complex have different modalities. So it can be electrical, thermal, radiation, and chemical. So there are various types of injuries which can occur to the peripheral nerve. What is important for us to understand from a mechanical point of view is that not every injury is equal, and there can be a lot of combinations which can occur. And there have been various work to classify these types of injury, starting with Seddon in 1942, who actually classified neuropraxia as those injuries where there are only some conduction block. The both axons and myelin are intact, and that's why there's no such EMG changes in these patients. But then when the axon gets injured, but the sheets is intact, then it is called axonotmesis. So these are lesions in continuity as compared to neurotmesis, where there's a complete division of the nerve. But then what they have seen later on that all axonotmesis do not behave similarly because of the different layering of it. So Sunderland actually classified axonotmesis into 2, 3, and 4 grades. And so one remains the same where there's only some myelin damage. So there will be some conduction block, but then of course this will repair on its own. But then 2, 3, and 4 will differ into what damage the sheath has also got involved in. So if there's an only axonal damage, it is grade 2. If there's an endorenal damage, there's a grade 3. So even till 2 and 3, they will take some more time, but then the recovery will be good, and most of the cases will actually occur, repair spontaneously. But type 4 is where the perineurium gets damaged. And if you see, remember the previous slide, the nerve, the blood nerve barrier is actually maintained by this perineurium. So once this barrier is breached, there's intense amount of scarring inside it. And that's why these Sunderland's grade 4 actually behave very erratically. And most of the patients would require some amount of surgical intervention, which I will discuss in the future slides. And the grade 4 has both epineurium damage per se, which can occur. So Lundberg in 1988 come with a classification of neuropraxia itself, where we classified it into type A and type B, whereas type A is a metabolic block, which is usually seen whenever we are actually sitting on a certain position for a longer time and we start having that pins and tingling sensation after that. But then these usually reserve within few minutes of correcting the posture, because these are not a permanent ones. These are very physiological compression thing. Type B is because of the edema, and that's why these particular changes stays for a few weeks from days. But then again, they recover on their own. McKinnon and Dallon in 1988 actually saw that most of these injuries, Sunderland types 1, 2, 3, 4, and 6 of 5, they do not occur in isolation. They will be mixed pattern of injuries, and that's why all these patients do not behave in a similar manner. So they give a different category of a grade 6 type of Sunderland, where there will be a combination of these injuries. Now, this is something which is very important for us to understand, because when we are prognosticating a patient, we are trying to evaluate and monitoring the patient as well as offering a treatment for these patients. These becomes the key basis for our intervention. Now, I will not be going into too much of detail in evaluation because Surya has actually covered it very, very well. What I would just like to qualify is further is that we should not only use a pattern way of evaluating things in these patients, but we also should have a very, very quantitative method of measuring the pain as well as the sensory motor deficits, as he has rightly correctly said. So writing that there's just a weakness, mild weakness, moderate weakness should not be the features to be noted. Rather, it should be specifically noted as a visual analog score, this much of pain or the patient is having MRC grade of this weakness. So that is very, very important for us to keep a note. Regarding the clinical examination, the measurement of gap is very, very important for us to understand, because if the suspected gap is less than, say, for example, 3 inches, then we would expect some recovery to occur within 3 months. If in case even after 3 months the recovery is not there, then that means the regeneration is not good and we have to intervene. Similarly, he has touched upon retinal sign, which has a sensitivity to as high as 67%, but the specificity of almost 95% of a regeneration potential. So if we do not see a retinal sign advancing within 1 month of injury, then we should again suspect this recovery is not going as per what is expected, and we should plan these patients for some intervention. So we should not just sit on the patient, but try to keep on evaluating these patients in a performer, which is very much helpful. So this is very, very important for us to understand that these clinical examination has to be done on a routine interval. So I explain all my patients, I see even if I'm asking you to wait for some time, this does not mean waiting for infinite time. You have to keep on calling the patient back and forth depending upon where the injury is, what is the deficit like. So if the deficit is almost 3 inches, I said earlier, you do not need to call the patient at 2-week interval. You can actually call them at 2-monthly interval to see whether the recovery is occurring or not. Similarly, electrophysiological workup, as he has rightly put up, should be done first at 3 weeks, and then we follow it at 8 weeks and 12 weeks. Again, depends upon the defect size, what we are measuring that. So again, I will not be talking about too much on electrodiagnostic, but then electrodiagnostic, you should always understand, is a secondary to our clinical evaluation. It is only going to help us in making or confirming a diagnosis, particularly having an idea what is going underneath the skin. But it should be always be taken with a pinch of salt, because it is very much operator dependent, and there are both false positive as well as false negative evaluation results which has come up, not only because of the patient factor, but also because of the cross innovation, which is routinely seen in a lot of variations, which again Surya has mentioned out. So that's why you should not take electrodiagnostic test as the final verdict. It should always be your clinical acumen and how the patient has progressed after the injuries. Now, this is again a summary of what happens in the electrodiagnostic test according to the Sunderland's classification. The other thing which you need to understand is the electrodiagnostic changes actually takes a temporal association. So not what's seen in a patient remains static. So the CMAB amplitude actually comes down within 3 days. There will be appearance of the fibrillation at positive and sharp waves, but then they will start coming down after 6 months or 8 months. So if you're screening a patient, after, for example, after 8 months, then you may not see a fibrillation or positive sharp wave. So these findings, they actually keep on changing. And that's why you have to understand the time of injury is very, very important when we are first evaluating the patient, because this is going to help you to understand where your electrodiagnostic changes stands. Other than that, MRI has improved a lot over the period. MRI neurography can actually help you to see the nerves, not only the pseudomonogenic, but also the high intense signal changes, both proximal and distal to the injury sites. And nowadays, ultrasound is coming in a big way, not only in evaluation of the brachial plexus, but also in the peripheral segment. You can go and evaluate it. It can also give you an idea what is happening to the secondary muscles or the muscles, target muscles. So the target muscles are getting atrophied. You can even have an idea by using an ultrasound as to what is happening to it. Now, this is a simple treatment algorithm which was actually propounded in 2000 by David Klein and his group. So whenever there's a peripheral nerve injury, it can be divided into open and closed. Now, open injury means active intervention. So if the patient has a sharp, neatly divided nerve supply, which usually occurs during the surgical maneuver, iatrogenic injuries, or a sharp cut with clean ends, one should always go with primary and early repair within 72 hours. Now, why within 72 hours? Because the more you delay the procedure, then there will be more edematous of the nerve ends, and that's why you have to cut more ends to get a healthy nerve fascicle. And so that's why the chances of a very good recovery occurs when we can, in fact, intervene in these clean cases within 72 hours. In cases of blunt injury where the nerves are contused or the epineurum are racked, then it is better to tack it and let the infection declare itself, let it get repaired by itself, and then you can come back after 2 to 3 weeks. But the only problem with this approach is that there will be some amount of scarring there will be fibrosis, or rather sort of some sort of neuroma formation in the cut ends, and these will require a lot of transaction to get the freshly fascicles at the tip, and that's what creates a lot more bigger gap as it was not before. So that's why you will require later on, when you're operating, a sort of a contour and a graft to manage that. In the close injury group, evaluation is the main baseline for intervention. So you do clinical assessment at multiple times. If the regeneration is seen both in clinical as well as electrophysical study, then we can just go with the conservative management. If in case recovery is not seen and there's a focal lesion, you should not wait for long. Waiting for only 2 to 3 months is good, and then you go for exploration and intraoperative nerve action potential monitoring. If there's a lengthy lesion, then you can allow some more time, but not beyond 6 months. So that should be a cutoff. And intraoperative nerve action potential is the thing whenever you do an exploration. So it can help you identify whether it is working or not. In delayed cases, in the primary cases, you can go for grafting procedures. And if in case in delayed cases or the salvage procedure, one can go for nerve transfers. So depending upon the length of the nerve defect, if in case there is a no nerve tissue loss or there's a minimal tension you can see by trying mobilizing the nerve, you should always go for end-to-end repair by trying to do an anastomosis or rather coaptation as soon as possible. However, if there is an avulsion injury, particularly in the sensory side, then you can try an end-to-end repair, or you can go for neurotization and nerve transfers. If the gap is more than 3 centimeter, and you know that even after mobilizing there will be some tension, it is better to go for a grafting. Either autograft is always preferable because it's less antigenic and much more better recovery has been reported. Allografts are a little costlier, and they have a problem that they will be requiring some amount of immunosuppressions to continue with that. So gap less than centimeter, again, you can go for autografting or tubulization with the natural conduits. So this is how the nerve action potentials are seen on in the intraoperative evaluation, and you can actually identify that your nerves are getting better or not after stimulation pre and post intervention. So when we say of management, neurolysis and nerve repairs are the primary procedures, followed by nerve grafts, allografts, neurotization, or supercharged enterocyte transfers as alternative procedures. And there are secondary procedures also which should be known to us, even though this is not the aspect I'm going to talk in this presentation, which includes functional free muscle or tendon transfer, arthrodesis or tenodesis, corrected osteotomy. So these are reserved for the late cases where the patients do not have any possibility of a neural intervention. So everything which we have said in both primary as well as alternate procedure have some limitations. So I will be talking in each of the detail. So the principles of nerve repair remains same across all what we are doing. So we should always have a generous operative field. Try not to do this procedure through a small exposure. This doesn't help. This actually makes your surgery much more tedious and difficult to achieve it. You should always have a good illumination, and microscope is preferable. If you do not have that, loop can also work. Anesthesia should be done with a short-acting paralyzing agent so that you can stimulate the nerve. And then flexibility regarding the position of the surgeon and the limb is preferable. So it's always better to drape the whole limb and then paint the whole limb and then keep it exposed so that you can see all the movements. Wide exposure, I've already said, and sharp dissection is very, very important. There is no role of using a peanut to dissect it. Always should be a sharp dissection from virgin tissue to progressing towards the lesion. And meticulous hemostasis with the bipolar cautery and a very low setting is important. And we should try to preserve the fat and synovial planes, because this are actually helps to keep the nerves gliding plane and also the vascularity. Now, the first procedure which we always try is neurolysis, because we all know that after the perineum is injured, there will be a lot of scar tissue around or within the nerve, which impedes regeneration by creating compression and entrapment. So neurolysis can be neurolysis where you can actually freeing the nerve from the surrounding scar, both in the transverse axis as well as in the longitudinal axis. So sometimes it is sufficient enough, and when you do it and you have a recordable NAPs, then this is good enough. Internal neurolysis, even though they have been propounded to free the nerve trunks or fascicle from the nerve tissue within the epivascular intervascular epineurium, it has been shown to damage the vascular plane and cause more scar. So whenever you are doing an internal neurolysis, it is always important to do a nerve action potential and try not to cause more injury. If in case there is something where you are looking at the patient and looking at the diminishing NAPs, and you stop doing it and rather going for a resection of the neuroma and then do an anastomosis will be far more better and superior results. However, even though this is a little bit contested, but then many reports, including by Kim, has actually suggested that the patients with radial and median nerve injuries have very good motor functional function to a tune of 98 and 95% after neurolysis. So this is just a small vignette where we can see a pre and the post-op patient of a radial nerve neurolysis, and you can see excellent recovery after 5 months. So these neurolysis patients do very well if in case they have to within a few months of repair. Primary neurography, on the other hand, is basically primary repair of these patients, particularly of the grade 5 patients. We are doing a direct suturing of proximal to distal stump, and enough mobilization should be done. And what is more important is to prefer an epineural repair over a fascicular repair as much as possible until unless it is not allowable. So in the epineural repair, what we are doing is we are only taking a part of the epineurium. Try not to take perineurium into it. So this is very important, but the only problem in these types of repair is that one has to keep the anatomical configuration of the nerve. So how can you identify it is by using the landmark of the vasa nervosa, which is traveling over the nerve. So if you can identify a vessel or you just try to keep the nerve loose at it, the nerve will fall in its own plane. So you can actually achieve that. And by using an epinural repair by 80, you can suture it is good enough to go there. So there are two processes by which you can make it laxer by using mobilization or transposition. And the redundancy should always be allowed at the place of repair. You do not have to create a redundancy here. Redundancy should always be there at the place of the repair. So whenever you are cutting the neuroma to achieve this primary repair, you should always see this axon, this fascicle sprouting out for the cut ends. This is very important to have an idea about the good axons, and this is just a clinical picture of how it looks like with a minimal tensionless repair. So again, a good clinical results in the peripheral measure we had. So nowadays we are using much more of the glue because it has been documented that more sutures we place, we are actually causing more scar. So this is a drip and drip technique within a dam, by which after using only 2 sutures at the at the opposite sides, we can use a glue and have a good cooptations. So gap or defect decides what you're using. So I've already covered to just save the time. So we can use a non-vascular cable graft. And this is the case where we have deconstructed almost a 15 centimeter defect of radial nerve. So we always take 20% more longer graft whenever you are using the defect. So we measure the defect and keep the graft more 20 centimeter longer than that. And this is a vascularized sural nerve graft, which we have taken before the transfer. And this is to be done if in case the distance or the defect is far more bigger. So this was used in this patient of a crust injury where we had some amount of benefit in this patient in pre and post-op period. So nerve transfers is a very beautiful thing which has come up to salvage these patients in a later phase. And the concept has come up because what we have found that it requires almost 80% innovation to lose the function. However, to gain the function, you only require a 30% innovation. So if you can take some fascicles of the similarly acting of the nerves, then you can have a good renovation of function capacity of the denervated muscle. So these are usually used when there are no proximal stem available, particularly in the preganglionic injury, where my mentor, Dr. Sumit Sinha, will be talking more in detail in the brachial injury coming in the next slide presentation, or in the salvage or the delayed presentation cases where you do not have long time for to wait, and that's why you are innovating as close to the muscle so that the innovation becomes much more faster. So this is ideally performed within 3 to 6 months of energy. We use similar working muscles to do that. So ipsilateral nerve transfers is always superior to the contralateral one. So there are certain sets of axon donor nerves and axon recipient nerves, which again will be covered by by the next speaker much more in detail. So this is just a clinical picture of how it looks like. In wake of time, I'm going to skip this off. And this is for the pronate teres nerve transfer for wrist extension in radial nerve palsy, which is performed for a patient in daily case. Nowadays, nerve transfers are also being propounded for lower limb injuries, where the superficial perineal nerve had been used to neuritize the deep perineal nerve, and partial tibial transfer has been done for deep perineal nerve injury. And cortical plasticity has shown that these types of neurosurgical intervention actually helps in providing the good function to the patient. So this is another case where there's an aversion injury of median and inner nerve, and they have received a very good outcome after these neurorestoration procedures. So these are various therapeutic procedures one can adopt at the peripheral nerve injuries and the various part of the body. There have been some alternative procedures, again, which has been documented in few case reports. So these are something where you are having a very desperate situation. We do not have anything. So direct muscle neurotization, interposed fees, DOS muscles, or central repair, which has to be done within 6 weeks of injury, where the oval spinal nerves are reimplanted into the anterior, into the spinal nerve, because anterior horn cells die after 6 weeks of inversion. So these are done in desperate situations where we do not have the primary procedures up in the hand. And as Saurabh actually mentioned, peripheral nerve injury is not a simple nerve injury. It can create a neuropathic pain. So they have to understand the various options for neuropathic pain, which can be pharmacological, as well as a lot of surgical intervention has come up these days. And we are doing it routinely in most of the patients who do not have a good pain relief even after 1 year of trauma. So ablation of pain pathways, DREs, or neuromodulation can be done. And to finish the talk, I would like to put an emphasis on supervised physiotherapy. All these surgeries are not a one-time game. We have to persistently motivate the patient and keep the patient calling back so that they can actually work with you. So there are many advances in tissue engineering, biomedical therapies. And now there talk of human-machine interfaces for these patients who cannot be helped by any of these roles. So the major impact which we have seen in a peripheral nerve surgery had been the ability to diagnose and classify the injuries, systematic, individualized approaches to peripheral nerve pathologies, more focal and focused intervention, steps to bypass time delay, and new modalities to enhance recovery and care. So to conclude, if possible, direct repair without graft, tension-free repair with healthy ends is the best choice, followed by functional assessment by intraoperative nerve stimulation using thin cutaneous nerve like Suril, because they get easily vascularized to deal with the defect if in case that it is longer than 3 centimeter. And when you're using these grafts, it should be more than 20 centimeter longer than the nerve defect. Shorter nerve graft, less than 10 centimeters are always better. If in case the gap is more than 30 centimeter, use vascularized nerve graft. And whenever you are planning a nerve transfer, use similar behaving neuromuscular units to have the best results. So this is my acknowledgement to my mentors and my the leaders of peripheral nerve surgery, whom I have learned a lot of things, and my team. And uh, 2 days later, that is on Monday, we are having a very basic talk on these types of injury from both our Indian faculties as well as faculties from abroad, from ACNS Peripheral Nerve Surgery Board. I would like to extend a warm invitation to you all on January 26th. So thank you for your patience listening.
Thank you, Dr. Amit Thapa, for your wonderful talk about management of peripheral nerve injuries. Our next speaker, Dr. Sumit Sinha, is going to talk about surgery for adult brachial plexus injuries.
Can you hear me all?
Yes, please go ahead.
Okay. So thank you, Dr. Kodishwaran and the NSI BOE and the NSI for giving me this opportunity to discuss one of my yet another favorite hot topics in neurosurgery, that is the brachial plexus injuries. And I'm so much thankful for the NSI BOE for this to consider about this. I would say mostly forgettable branch of neurosurgery, that is the peripheral nerve and brachial plexus injuries. So kind of you to include this into your curriculum of BOE. So to start with, I would like to pay my salutations to my teachers, my guru, my mentors, Professor V.S. Mehta, and he needs no introduction. He is a global leader and a wonderful neurosurgeon whom we have all been taught us, and we have been all grown up practicing and learning his teachings of neurosurgery, and especially brachial plexus and peripheral nerve surgery. So my talk will be in these three parts: what to do and when to do and how to do in adult brachial plexus injuries. And at the end, I would like to, to exemplify it with my own personal experience of the last 25 years that I've been practicing this. Now, look, as to what to do when encountered with this brachial plexus injury. And before I go into, I have to clarify that I am only dealing with the adult plexus injuries, because in OBPI, that is the obstetric palsies, it's a different ball game, and we have to consider many different things altogether. So now, talking about what to do, whether to operate or conservative treatment when we first see the patient with brachial plexus injury. If suppose it is an open injury and it is a clean open injury, then we always recommend to explore the wound immediately, especially if the wound is healthy. However, if it is a clean incised injury, then we choose to do an end-to-end anastomosis at the same setting. And in cases of contaminated open injuries, it is recommended to operate after 3 to 4 weeks. And after the wound heals, the nerve ends, however, they should always be tagged. They should always be tagged at the time of initial primary surgery, because after 3 to 4 weeks, when you reopen that, it is easier to identify those tagged nerve ends in the deep tissue fibrosis. So just like any other surgical principle. In cases of close traction injuries, which are of a common occurrence in our clinics, what is recommended is to follow the patient clinically and with electrophysiologic monitoring and with radiologic studies like MRI and MRI myelography. And if suppose there is a distinct evidence of root avulsion on all these three modalities, then immediate neurotization or nerve transfer is recommended, because there is very little or no possibility of a spontaneous recovery of these injured nerve roots which are avulsed from the spinal cord. However, if these findings are suggestive of postganglionic injury, then it is prudent to wait for 3 to 4 months and do serial clinical evaluation of the patient, do an electrophysiologic monitoring every 3 to 4 weeks, see for any signs of improvement on these tests. And if it is improving, then you follow this conservative routine, and till the time the improvement stops to continue after some time, when it is recommended that exploration is warranted. So this is the algorithm for the close traction injuries. Now let's see as to when to do. Now this is a very big question in peripheral nerve and brachial plexus injuries, as to what is the appropriate timing of the of your surgical procedure. So there are certain advantages and disadvantages of an early surgery vis-a-vis delayed surgery. The advantages of early surgery are that we can get an early identification of the nerve avulsed or the broken ends, and because there is a clean surgical field at this time, fascicles are identified in a very nice manner. And of course, after the surgery, we can do an early rehab for the patient, start an early physiotherapy for him with distinct advantages. The disadvantage is that sometimes if you repair an early healing neuropraxic injury, you may lose spontaneous regeneration and inadvertently go on to repair surgically this type of a lesion. So in other words, the cases which are capable of a spontaneous recovery are inadvertently resected and grafted. So in delayed surgery, the advantages are that the neuropraxic injuries, they do recover, as I said, and therefore there is no need for any surgery in the later stage. And the disadvantage is that when you open it late, there is a progressive intraneural fibrosis which happens and makes the surgery difficult. So you have to be very wise enough to choose the timing of surgery. It has been seen that the brachial plexus injuries, which are not showing spontaneous recovery within 3 months, they need to be explored, because there is a physiologic rationale to this disease, and because the neuromuscular junction, which which is at the junction of the muscle end plate, it degenerates at 20 to 24 months after the injury. And suppose you make an anastomosis there at the level of the shoulder or the neck, and the nerve, the regeneration of the axon, it takes around some 1 millimeter per day. So by the time it reaches the end plate, the end plate should be healthy and viable. So this is the rationale for doing the surgery within 3 months of the injury. So it has been seen repeatedly that the best window is the first 3 months, and the next best is in the subsequent 3 months. And the results, they do fall significantly after 6 months of surgery. However, in global palsies with pseudomeningocele suggestive of a preganglionic injury, as I already said, there is no delay to be justified. In partial plexus or postganglionic injuries or upper plexal injuries, it is prudent to wait for 3 months for neuropraxia to recover in the functioning roots. These are the indications for an immediate or early repair, as much early as possible, because all of these indications, they show that the quantum of the injury was so massive that there was probably a preganglionic injury causing avulsion of the nerve roots from spinal cord. And therefore, the potential for recovery, spontaneous recovery, is very, very less. So these are the sharp open injuries, any associated vascular injuries, if there is a flail limb with severe neuralgic pain, and if we are fortunate enough to see pseudomeningoceles on MR myelography. So this is an indication for an early repair. The indications for delayed exploration, as I already said, within 3 to 4 months is when we have a distal recovery in the hands without regaining a clinical or evidence of proximal recovery in the shoulder muscles or in the elbow muscles. So this is what delayed exploration indication is. Now, let's see as to how to do what type of surgery. If we have chosen the surgery, if we have decided that we are going ahead with this surgical procedure, then what type of surgery are we going to do? Now, the next few slides are going to be the most important slides. And I would like to spend some time on that, because so before we go there, then there are some principles to be known about the brachial plexus microsurgery, some of which, most of which have been lucidly described by the previous speakers in this webinar. Other of them are always re-innervate the recipient nerve close to the target muscle, so that the axon, the regenerating axon, has to travel the least distance up till the neuromuscular junction. Whenever possible, perform a direct repair without the using of the nerve grafts, because every time you use an anastomosis, you lose 1/3 of your axons there. So by the time it reaches the NMJ to an anastomotic line, 60% of axons are lost. So we are left with only 30% of the axons of the initial donor nerve. So that is the most important thing. However, this repair should be always tensionless, and it should be supple enough to so that it does not break during normal physiologic movements of the arm. Whenever possible, use similarly behaving neuromuscular units, and choose similarly behaving donors and recipients. And for this reason, intraplexal donors, whenever possible, they are preferred over extraplexal donors. And perform the transfer surgery as early as possible, as I already mentioned. Now, one word about the neuroma. In continuity, there is a term in brachial plexus surgery called the neuroma in continuity. What we do is we stimulate the neuroma during the surgery proximally, and if we get any stimulation, any current, or any muscle movement distally, then we say that this is probably a neuroma in continuity. And the traditional teaching has been that do not cut the neuroma, because it is probably has containing regenerating axons, and maybe might not require a surgical nerve transfer. So found in continuity, then do only an external or an internal neurolysis. However, if there is no nerve action potential recorded or no muscle stimulation distally, then you are justified in doing a resection of the lesion or the nerve transfer, whatever feasible. So these are the two treatment strategies for brachial plexus injuries. One is for the nerve repair, which are dealing with neurotization or the nerve transfers. And the other one is the secondary procedures or the so-called tendon transfers, which are mostly done by orthopedic surgeons and plastic surgeons. So let's see a few words about the neurotization. Now, neurotization is a nerve transfer procedure, which is the transfer of a functional and less important nerve to a distal but more important denervated nerve. Then the indications are the root avulsion or a proximal preganglionic injury. And these are the various intraplexal donors which we prefer to take, and mostly whenever possible. And the extraplexal donors are also listed over here just in case you are not able to get in cases of global palsies, there are no intraplexal donors. So the next three slides will be for the injuries which we commonly see during our clinical practice, sitting in our OPDs. So these are the strategies for C5-6 injury. So in case of a C5-6 injury, the patient will not be able to abduct his shoulder and flex his elbow, and the extension, that is the triceps, will be perfect. So what we can do in cases of preganglionic injury, this is a procedure called triple transfer. And we do, first of all, for shoulder abduction, we do two procedures. One is the 11-2 supraScapular anastomosis, which achieves the shoulder abduction till 15 to 30 degrees, and external rotation and stabilization of the shoulder at the same time. And we complement this procedure for shoulder abduction with the Somsek procedure. Now, the Somsek procedure is a distal nerve transfer, in which we anastomose the nerve to the long or the lateral head of triceps to the anterior division of the axillary nerve. Or we can do a thoracodorsal nerve to the axillary nerve transfer. So two procedures for the shoulder abduction and another one for the elbow flexion, in which we can do an Oberlein procedure where we anastomose the ulnar or median nerve fascicle to the branch of the to the biceps branch of the musculocutaneous nerve. So this is the procedure done in the preganglionic injuries. This is the distal nerve transfers, triple transfer technique, which we can do to achieve shoulder abduction and elbow flexion. In cases of early postganglionic injuries where we have a viable stump proximally, we can anastomose the C5 stump to the lateral cord or the upper trunk to achieve the shoulder abduction and elbow flexion. And we can do the C6 to the posterior cord anastomosis. So let us see for the C5, 6, 7 injuries, in which case the elbow extension also is gone. So in cases of preganglionic injuries, the same procedure, the triple transfer is to be done. And with this triple transfer, we can add procedures for elbow extension also. So in this, we can anastomose the medial pectoral nerve or the intercostal nerve to the long head of triceps branch of radial nerve, so as to achieve the elbow extension also. In cases of postganglionic injuries where we have a viable C5-6-3, all the three stumps are there, then we can choose to anastomose the C5 to the lateral cord of the upper trunk and complement this with the C6 to posterior cord anastomosis and C7 to middle trunk of the posterior cord. So we reconstruct the entire plexus in a way. In cases of C8-T1 injuries, we can do ipsilateral or contralateral C7 transfer to the lower trunk or the medial cord. Now, the contralateral C7 deserves a special mention, because especially in adults, because in my hands, I am not very happy with the results of contralateral C7. So in my practice, it is not normally, I don't use it very, very, very often. However, in literature, especially from Chinese colleagues, Gu and colleagues, they have a mastery over this contralateral C7, and they are very, very frequently using it along with some of the authors in the Western world. In the late cases, what I particularly do is to transfer the nerve to brachialis to median nerve or the ulnar nerve, and nerve to brachioradialis or the supinator to the posterior interosseous nerve. So it gives the wrist extension and the finger extension as well as the flexion of the fingers. In cases of global palsy, the last of this important slide about what type of surgery, this is a very, very dismal situation. And paradoxically, we get approximately half of the patients of brachial plexus with this devastating injury. Here, what happens is the donor nerve options are very, very less, and there are extraplexal donors only. So there is a very little chance for recovery for the, especially the hand function. But whatever is there, which we can obtain with this, whatever so little which is available, we can do an 11th nerve to suprascapular anastomosis to achieve shoulder abduction and external rotation of the shoulder. We can do second, third, fourth intercostal nerve to musculocutaneous anastomosis to achieve elbow flexion. And maybe we can use the fifth and sixth intercostal nerve to the radial nerve branch to achieve some of the elbow flex extension. However, I do not use the intercostal nerve for elbow extension, because if you use the intercostal nerve for elbow flexion and simultaneously for elbow extension as well, it does not give generally good results. So what I do is, in cases of global palsy, only the 11 to suprascapular or phrenic to suprascapular, and complement it with the second, third, fourth intercostal with the musculocutaneous anastomosis to achieve the elbow flexion. Now, these are the secondary procedures which our plastic surgeon friends do for delayed presentations and for failed nerve transfers. And one of the most common technique is the free functioning gracilis transfer, and wrist fusion techniques and other shoulder tendon transfers to improve hand function for grasping. So let's see quickly as to how these exposures are done, because I think this is very, very basic for anyone starting with the brachial plexus career. And for the suppressed clavicular exposure is meant for exposing the roots and trunks. And for the infraclavicular exposure is meant for exposing the divisions, cords, and distal branches. And the indications for are these for the supraclavicular exposure. And I don't know why it is not progressing. Hello?
Yes, sir, we are hearing, sir.
I don't know why it has gone, my slides. Are you able to see my slides?
Sir,
No,
we are
the
seeing your you in profile, but not your slides.
I will share it again. I don't know what happened. Oh, it's amazing. I'm sorry for this. Just a minute. I don't know what happened. The presentation, where is the presentation? It's gone. Very strange. Give me 30 seconds, please. I'm sorry for this.
Yes, sir. Please continue, sir. It's your time, sir. No problem.
Oh God.
Yes, sir. This is the one.
No, this is not the one. I mean, I don't know where it is gone. This talk of mine, where it is gone. I don't know. Yeah, okay. But it is not advancing. Very strange. It is not advancing. My slides are not advancing.
it's moving.
No, it's not. The slides are not advancing though. It's not amazing.
You can present like this, sir, without the slideshow.
Video is playing.
Yeah, okay. So I'm sorry for that, for this. I don't know why this is happening, this weird thing. So this is a short snippet of the supraclavicular exposure. And let me orient you that the this side of the screen, this is cranial and this is caudal and this is medial. What I'm doing is doing phrenic to suprascapular anastomosis. This is the upper trunk. And here is the phrenic nerve, which I stimulated just using my stimulator. And then I'm trying to find out the suprascapular nerve, which arises from the lateral aspect of the upper trunk. So I just stimulated the suprascapular nerve, and then I'm going to harvest this nerve as long as possible. Remember, the donor has to be harvested as distal as possible and recipients as proximal as possible to the NMJ. Now I am harvesting the phrenic nerve on the anterior border of the scalenus anticus muscle, and I have already stimulated that, proving that this phrenic nerve is functional. And I harvest this whole length of phrenic nerve, cut it as distal as possible. Sometimes there are 2 or 3 phrenic nerves called as accessory phrenic nerves, and we are fortunate at that part. I harvested this entire phrenic nerve and then rerouted it to be anastomosed to the suprascapular nerve. Suprascapular nerve is a monofascicular nerve, and we have proved it in our earlier publications also. And this nerve is to be cut as much proximally as possible, and then cut as according to wherever possible we get the viable fascicles. And then what we do is we anastomose this, as you see, tensionless. And what I do generally is I just anchor 1 or 2 anchoring stitches on the perineurium, and then later on do a tissue welding with a tissue glue. So this is what the completed suprascapular 11 nerve anastomosis. This is another procedure which is very, very common, intercostal nerve to musculocutaneous anastomosis, and this is the bread and butter of a brachial plexus surgeon. And this is the right-sided operation in process, and this is the whole long scar which we do. We raise the pectoralis major muscle flap and then dissect the serratus anterior along with the pec major. And then what we do is we identify the second, third, and fourth ribs, cut the external intercostals, and harvest the intercostal nerves which run along the lower border of each rib. So we harvest it from the mid-axillary line to the anterior aspect of the chest, where it penetrates, the sensory nerve penetrates and goes to supply the skin over it. And we identify the motor nerve only. So there are 2 nerves running close approximation of each other. And how do we identify both of these nerves? We are usually interested in the motor nerves, motor intercostal nerves, and we identify it by seeing that the motor nerve is thinner as compared to the sensory nerve, and motor nerve also stimulates when we give a low intensity current to the motor nerve. So we harvest these 3 motor nerves, beautifully harvested from this, and then we anastomose to the most proximal aspect of the musculocutaneous nerve, so that these 2 nerves reach each other without tension. So this is a short video, and this is you see, but we see them, and then we raise the pec major flap, and then we are harvesting the intercostal nerves from the lower border of the rib. This is the fourth rib, which is we are harvesting the fourth intercostal nerve. And this is the nerve which I told. This is the motor branch of this. We take it into a vascular loop. And then we harvest the whole length of this motor nerve right up till the anterior end. And then we harvest 3 nerves, make it into a single bundle, and glue them together, and then anastomose it to the musculocutaneous nerve. So this is what ultimately it looks like. This is some of the patients whom we did the intercostal to musculocutaneous. And SOMSET transfer, another distal nerve transfer, which we do in cases of partial injuries for achieving the shoulder abduction. So I don't know why this is not playing. Anyway, this is strange.
Sir, it's playing, sir.
Yeah, okay. So this is another nerve transfer which we do in cases of achieving the axillary function. Especially in cases of triple transfer, we augment this with the spinal accessory to suprascapular transfer. And anyway, forget it. So Oberlin transfer is another transfer which is used for the achieving of the elbow flexion, and there are two forms of Oberlin transfer, 1 and 2. This is not playing here, which is okay in interest of time also. So what I do is generally I do Oberlin 1 and 2. In Oberlin 1, we take the ulnar nerve fascicle and anastomose it to the biceps branch of the musculocute, and also augment it with the median nerve fascicle and transfer it to the brachialis branch also in order to achieve elbow flexion. So this is what my personal experience was all about. Operated over a past period of 25 years, a total of about 1,005 cases, most of them done in the setting of All India Institute. And as you can see, these are the number of cases. Mostly the cases which I did, they came during the time window of 3 to 6 months after the injury. Total patients, the follow-up was maintained as much as possible with the 3 monthly OPD visits, telephonic surveys. We have a minimum follow-up of 16 months and maximum of 15 years. And 214 patients, they did not respond or lost to follow-up. So as I said, I'm not very big fan of neurolysis. So as you can see, only 21 cases of neurolysis. Howsoever, whatever little number is there, I achieved satisfactory results at that time in the initial part of my career. I used it. Plexal reconstruction also not very favorable nowadays. I do own most of the times on nerve transfers. As you can see, the best nerve transfer results in cases of suprascapular to spinal accessory to suprascapular nerve, and phrenic to spinal accessory, 62% grade 3 PAR results, musculoquiote intercostal nerves, and intercostal to radial nerves, anastomosis. And the best results of the distal transfer is the SOMSEC transfer and the Oberlin transfer, 82%, 86%. Forearm transfers for achieving the finger flexion, AIN to PIN transfer for the wrist extension also carries. So all distal transfers, they carry the best results in cases of brachial plexus injuries. In fact, I would say that the last decade and a half, these transfers have changed, completely revolutionized the results of brachial plexus surgery. These are some of the results of my operated patients. Some dated back as much as 20 to 25 years back. Triple transfer. This is a follow-up of 11 months. And some of them. So in cases of ICMC anastomosis, the result, the first result which becomes available is at 11 months to 12 months. And this is spinal accessory scapular, which is a complete range of impact with this ICMC at 28 months. Another SAN to SSN bypass and ICMC at 42. You can see the good outcome with this technique. With this, this is the triple transfer, which is the follow-up at 18 months. The patient is able to lift his hand well beyond the range of motion. And another similar spinal accessory to suprascapular transfer and ICMC bypass for at 19 months of surgery. Neurolysis again, from the beginning of my career. As I told, I do not do anymore this neurolysis. And the lower video is of the spinal accessory. So triple transfer on the ICMC bypass. So this beautiful young kid I operated about when she was this little girl about 10 years back. Now she has grown up into a beautiful young lady, and she has multiple tendon transfers and after that, and she has had a quite functioning hand at the present moment. So these are some of my publications which I recommend the younger colleagues to read and learn about. This was our paper in Journal of Neurosurgery about the fascicular topography of brachial plexus. And these are some of the books which we published. So the take-home message is, yes, some of the treatment can be offered to these patients. Remember, no patient should be without any treatment. Why? Because some of the if you give some of the movement to these unfortunate patients, they will be very, very happy. Something can be better still rather than having nothing. So early referral, early treatment has got better results for obvious reasons. Partial injuries, they have got better outcomes, and selective combinations of neurotizations, they give good results. And of course, yes, multi-specialty approaches involving hand surgeons, plastic surgeons, and the role of physiotherapist is a special attention is required for these patients. I always recommend my patients that I won't do surgery if you are not ready to do a physiotherapy at least 4 to 6 hours a day after your surgical procedure. So I think that's it. Thank you so much for patient listening, and sorry for taking long time. Thank you so much.
Very nice and highly informative presentation, sir. Very nice. Thank you, sir. Thank you so much.
Thank you very much, sir. Now we invite Dr. Chandan Mohanty to speak upon surgical management of obstetric PPI.
So good evening, chairpersons and panelists. First of all, thank you to NSI and the Board of Education and Professor Kodishwaran for giving me this opportunity to talk about neonatal brachial plexus injury. So a lot of my presentation, I'll be building on the points which have been made by all the three speakers previously. And I would, for this presentation, what I'll do is I'll try to restrict most of my discussion on the differences between the neonatal versus the adult brachial plexus and the principles of management. So first of all, I mean, we know that the incidence of neonatal brachial plexus injury is not very low. It's 0.1 to 0.4%, and most commonly affected roots are the C5 and the C6 roots, and the supraspinatus and infraspinatus are the most commonly associated muscle. Now, the most common cause is actually presence of macrosomia and breech presentation. Maternal causes can be presence of shoulder dystocias, diabetes, and CPDs, and prolonged second stage of labor. So now the trend has been to stop using the word obstetric brachial plexus injury and either call it neonatal brachial plexus injury or brachial plexus injury in the newborn, because this is one of the most important factor that patients usually come to us. Patients who are 3 years, 4 years old, they are basically not completely understood the nature of the problem, and they're probably looking for someone to blame at. So it is important that what we do is the first session is always very difficult when the patient is referred to us, because they end up blaming the obstetrician for this. So we have to explain to the patient that the obstetric maneuvers are necessary to save the life of the newborn, and sometimes you can have these traction-based injuries to the brachial plexus as an outcome. So some of the points which are against the so-called obstetric origin is that the left occipito-anterior position in the pelvis is the most common fetal position. Hence, by default, what you should see is almost a right-sided brachial plexus injuries to be more common than the left. But that is not what is seen in the literature. We almost see a 50-50% outcome. And more than 50% of cases, there is no associated shoulder dystocias. Now, there are also studies which have shown that there is probably a genetic outcome. So if the first child has brachial plexus injury, there are some papers which show that it is autosomal dominant in nature, and so the second child can also have brachial plexus injury. So the other thing is presence of uterine malformations like a septum or biconjugate uterus can also predispose to a brachial plexus injury in the newborn. Now, interestingly, there was this one very interesting case report which was published. So the child was born with a neonatal brachial plexus injury, and what they noted was that for some reason the obstetrician ordered a EMG and a nerve conduction study on day 1 of delivery. So now, from all the previous lectures, we have seen that the Valerian degeneration takes about 3 to 4 weeks to start developing after the initial nerve injury. So if a EMG and nerve conduction study was done on the first day after delivery, we should not have picked up any changes on EMG and nerve conduction studies. But interestingly, in that case report, they noted that denervation potentials were noted on day 1 of birth. So that tells us that probably there's also some intrauterine factors, very high maternal expulsive forces which act on the fetus when the child is in the fetus, that may be also be one of the responsible factors for causing neonatal brachial plexus injuries. So as a nerve surgeon, it is important that we avoid commenting on any kind of medical legal liability. We always give parents education, the current evidence, and some handouts, and obviously avoid using the word obstetric rather than and use the term neonatal as a common as a entity to as a nomenclature to describe this entity. Now, there are multiple classification systems for the neonatal brachial plexus injury. The most common one is one by Naraka's classification, which describes the upper herbs, which is C5, C6, extended herbs being C5 to C7. Then total palsy with no Horner's, which is all the roots C5 to T1 without Horner's. And total palsy with Horner's, which is C5 to T1 with the Horner syndrome. Now, considering the age of the patient, now there are multiple outcome measures also. Then there's this active movement scale, which is commonly used, which is almost very similar to the MRC grade that we use in adults. There's also the Toronto score, which has been developed to further classify and further find out the various differences in the various movements and the recovery of muscle. Then there is this mallet score, which is more like a visual representation of the hand movements and the shoulder movements from this pictorial representation. Now, one of the most simplest things to do is that in a child, the most important thing for examining the child is actually to observe the child. So for observing the child, this is a very simple rule which was given by Gilbert, which is called as the Gilbert's rule. So by Gilbert's rule, it states that if a child with upper brachial plexus injury at the 3 months of age, if he is able to bring his hand to the mouth, that means the biceps function is 3/5. So in such patients, the recommendation is if 3 months they are able to perform the cookie test, that is bringing the hand to the mouth, the child should just be observed because you can expect spontaneous recovery in such children. However, if at the age of 3 months, we see that the biceps function is not 3/5, then probably the child is a candidate for an early brachial plexus intervention and surgery. Now, this is a very important sign called as a trumpet sign, in which basically what the child is doing, a child is basically abducting his arm and then flexing his elbow by eliminating the gravity. So this is almost like kind of a cheated movement in which the child is able to bring the hand to the mouth, but it is not by using the biceps in an anti-gravity manner, but by using the shoulder as well as the sometimes in the brachioradialis to just bring the hand to the mouth. So that is called as a trumpet sign. This is a very important sign. The other test which can be performed is a towel test. You simply put a towel on the face of the child, and if the child is able to pull the towel out from the face, you know that the biceps function is recovering well, and there's a high probability that the child will spontaneously recover his or her function. So this is a classical herb sign that you see. This is called as a shoulder tip deformity. You can see that the arm is adducted and hyperpronated with flexion at the wrist joint. Now, radiology, I think most of you are aware of that. One of the most important things that we do is look at the MRI. MRI is usually performed after 1 month of age, because by that time the pseudomeningoceles, which are usually associated with avulsion injuries, are formed at that time. There is no role of doing an MRI in a very acute or a hyperacute phase. The MRI can sometimes also identify denervation changes in the muscles. So you can see edema in muscles which are actively denervated, and atrophy in muscles which are chronically denervated. You can also assess the phrenic nerve to look for the phrenic nerve functions, which can be seen in very, very severe brachial plexus injuries with the ultrasound. So the movement of the diaphragm can be easily assessed with the phrenic nerve. Now, as I told, the EMG nerve conduction is generally performed at 3 to 4 weeks. I won't go into this directly. As far as intraoperative monitoring is concerned, so intraoperatively, I find that nerve action potential and CMAPs are not very useful for decision making. So most of your decision making is based on the clinical examination of the child and the preoperative EMG and nerve conduction studies. However, intraoperative direct electrical nerve stimulations are useful to identify the motor fascicles. So now coming to patients who fail the cookie test, which is the Gilbert's rule. So in patients who have a complete palsy with avulsion of roots seen on the MRI, usually we recommend these children to undergo surgery at earlier age. So sooner the better. That's usually the preference. Now, in terms of restoration of strength, as Professor Sumit Sinha told in his previous slide, the priority for restoration of function in a child is different in a child and in an adult. In adult, if, for example, with a panbrachial plexus injury, the focus is more on developing shoulder abduction, elbow flexion, and even elbow extension. However, in a child, the priority is mainly to develop the hand function, then the elbow flexion, and in the end is the shoulder abduction and rotation. Now, the reason for this is that the reinnervation distances in the child are much smaller compared to the adult. So Professor Amit Thapa told you about the end plate changes which happen within 1 to 2 years after the nerve is denervated. In a child, because the distances are short, the hand function has a much better chances of recovery. And for the shoulder abduction and shoulder rotation, you can rely on secondary procedures, orthopedic procedures, or even tendon transfer. So priority for nerve repair is the hand, and followed by hand is the elbow flexion. So typically we explore the plexus. We can then remove the neuroma, excise the neuroma, and then just perform a grafting. There has been no direct comparison of nerve grafting versus nerve transfers in primary repair. And interestingly, in children, the results of nerve grafting and nerve transfers are almost similar. Neurolysis alone, as Professor Sumit Sinha has said in his presentation, has almost no role in neonatal brachial plexus injuries. We follow this rule, that is, the donors are distal and recipients are proximal, as Dr. Sinha beautifully showed in his operative videos whenever we are performing the nerve transfers. So just encapsulating the basic differences between the neonatal and the adult brachial plexus injuries. So the mechanism in neonatal brachial plexus injuries is intrauterine forces and traction, whereas adult is mainly road traffic accident and high velocity. When we look at the pattern, the herb and the herbs plus are the most common, constituting more than 50%, whereas in adult, the global palsy is more common. The muscle strength is usually assessed by scores like the AMS score, the Toronto scale, and the modified Mallet scale, whereas the adult, the MRC grade has stood the test of time. In terms of children, because the recovery potential is much better in children compared to adults, because they have only shorter lengths for the nerve to regenerate. We know that the nerve regenerates at the rate of 1 millimeter per day. So because the lengths that the nerve has to travel is short, therefore the recovery potential is better. Also, children have more brain plasticity compared to adults, so their outcomes are generally much better compared to adult brachial plexus injuries. Now, as I told you, the priority for reconstruction is hand in children, and then elbow, and then finally shoulder abduction and rotation, whereas the proximal muscles take precedence in an adult. As far as surgical techniques are concerned, nerve transfers and nerve grafting are almost has equivalent results as per the literature and as per my experience. We'll come to that in the next few slides. Whereas in adults, we see that the nerve transfers have a much better outcome. Now, in neonatal brachial plexus injuries, there are now reports which show that even surgery performed 18 months to 40 months, so almost at the age of 3 years after the initial injury, are showing some improvement in the motor recovery. So the oldest child which I have operated is about 2 years of age, and the child is still on follow-up, but that child has already started showing recovery of the biceps muscle. So there is some data to show that probably the end plate changes in the neonatal age group do not happen as quickly as they happen in adults. So there may be a role for late surgeries in neonatal brachial plexus injury also. Now, very interestingly, one more major difference between neonatal and adult is adults have a very high incidence of developing neuropathic plane complex, whereas in neonatal brachial plexus, you almost never see a neuropathic pain complex. Instead, what we see is limb length discrepancy, because the growth of the nerve also increases the length of the limb. So the bone and the muscles, the soft tissue also follows the nerve. So if a child is having a nerve injured hand, then if the child is having a nerve injured hand, then the chances of having a same size of hand is lower. And the very common thing that we see in children sometimes is a process called self-mutilation. They bite off their digits if they do not have any sensation in their fingers. So the self-mutilation and auto-amputation are also seen in neonatal brachial plexus injury. So you might need to protect these children when they are undergone surgery. So now this is the same thing which I spoke about in the previous slide in a diagrammatic manner. So once they fail the cookie test, we often recommend surgery for these kind of patients. And so, say for example, in this diagrammatic representation, we have what is a neuroma in continuity, which is very commonly seen in the herbs pattern in C5 and C6. Here, we can safely excise the neuroma as close to the foramen as possible, and then we can use nerve grafts to basically bridge the C5 to the suprascapular and the posterior division of the upper trunk, which will take care of the axillary nerve and the radial nerve. We can take the C6 root and graft it to the anterior division of upper trunk, which takes care of the musculocutaneous nerve and the median nerve. Now, in cases where you have this kind of multiple avulsion injuries, now as I told you, the priority is always restoration of hand function. So in these kind of avulsion injuries, mainly these avulsion injuries happen in the lower roots, that is the C8 and T1. So what we usually do is we directly anastomose or coapt the C6 to the C8, which gives hand flexion. And the C5, we usually use either a graft or direct transfer to the upper trunk that will give some function to the proximal muscles. So these are the nerve grafting procedures. These are almost never used in adults because the reinnervation distances are quite long. Now, the graft sources that we usually use are you can use the supraclavicular nerves, you can use the sural nerves. One which I prefer very much is the medial cutaneous nerve of the forearm, because it's right there in the field when you want to do the overlines transfer, and you can safely use that and gives a fairly large graft segment if needed. Now, there are papers which show that you can also harvest the nerve through an endoscopic approach, so with a much smaller incision. So, but I don't have any experience in that, but that has also been described now recently. So this is an example of a C5, C6, and C7 palsy. So this is basically what we call as an extended herbs by the Naraka's classification. So in this child, we have done is a spinal accessory to the suprascapular nerve transfer, and then we have done a Oberlein's transfer here, which is basically taking the fascicle from the ulnar nerve to the biceps muscle, and then we have identified the intercostal nerve. So you see that we are identifying the ulnar nerve fascicle, which will be ready to transfer to the biceps. So that's the biceps that is directly being stimulated. And this is the motor division of the intercostal. So two intercostals will be coapting it to the axillary nerve. The incision is behind, so it will be, we'll move the arm across the shoulder. So in addition to these nerve surgeries, it's important that this child will always be coming to you, because once the nerve repair part is completed, there are a lot of secondary procedures and secondary complications which can happen in a child. So some of the complications which can happen are co-contractions, presence of contractures when the physiotherapy is not adequate. You can have glenohumeral dysplasia, which is basically dislocation of the humerus out of the socket. There can be sometimes suboptimal recovery of certain muscle groups. In that case, you can probably perform a tendon transfer like the latissimus and teres major to the posterior rotator cuff to give you adequate shoulder abduction. Now, this co-contraction is basically because what happens is there is no specificity of the proximal nerve to the distal nerve. So the nerve root, which is supposed to go to a particular fascicle, doesn't go there, but instead goes to the antagonistic muscle. So you end up having a mixed reinnervation pattern. You commonly see these kind of biceps and triceps co-contraction and teres major and deltoid co-contractions. So biceps and triceps co-contraction, in which you see very good contraction of the biceps, but the child is still unable to flex the elbow completely. So that usually raises the suspicion when you see good muscle contractions, but the movement of the hand or movement of the elbow is not very good. So we usually use these Botox injection. The Botox is given at a dose of 2 to 3 units per kg. And we prefer to give it in biceps, triceps co-contraction. And also sometimes when you see this internal rotation deformity of the shoulder, where we inject in the muscles which are hyperadducting, that is the teres major and the pectoralis major. So you can see this patient. The child is now bearing weight on the operated side, but you see that the child is not able to abduct, and this muscle, that's the teres major, is completely having contractures there. So for these type of co-contractions, we often give them injections of Botox to paralyze the muscle, and then that will allow the biceps to act in its full range. The glenohumeral dysplasia, as I told you, was basically retroversion or slippage of the humerus from the glenoid cavity. And if you have a high grade glenohumeral deformity, in spite of having a good nerve recovery, the patient may not have very good shoulder abduction. If it's high grade, you might need to include your orthopedic calling and do a humeral rotational osteotomy. If it's low grade, then you can probably just ask one of your plastic surgery colleagues to perform a contracture release of the hyperacting muscles. So these are some of the tendon and muscle transfers in which you can perform in the children's brachial plexus injury, which I've told before. So just a few slides of some of the rehabilitation methods. Now, this is very important because, as Professor Sinha also emphasized, that surgery is only a step in the overall management of a patient with brachial plexus injury. Once the nerve surgery is done, the patient might require orthopedic or plastic maneuvers, but the patient will always need physiotherapy at every stage of recovery. So this is the very commonly used, which is the CIMT, which is constraint induced movement therapy, which has level 1 evidence. So mainly used in CP and stroke, but now has also been used in children. So what we do is we tie the normal hand of the child and we force the child to use the affected hand more and more. So we usually tie the normal hand for about 1 to 2 hours in a day, and then we expect the child to use the nerve affected hand so that it basically rewires the brain in such a way that it leads to improve neurological outcomes. So this is just a homemade technique which was done during COVID by the patients, and they would be graceful enough to send us the videos. You can see that the child is holding her cat with the nerve affected hand which has undergone surgery, and this is the normal hand which has been tied. Same thing, one more example, hand has been tied and the child has been introduced new toys at that time, so it forces them to use the nerve injured hand more and more. Now, electrical stimulation again is very important because electrical stimulation of the affected muscle increases the local nerve growth factors and the brain-derived neurotrophic factors. Also prevents muscle atrophy and improves blood flow. And this also has level 1 evidence to show that electrical stimulation actually leads to improved outcomes. Now, as I told you, in terms of nerve grafting and nerve transfers, we see for the restoration of hand function, nerve grafting, especially in pan-brachial plexus injuries, is very, very useful with efficacy reaching as high as 66%. So 2/3 of patients make a good recovery. For elbow flexion, nerve grafting shows good result in 80% of cases, whereas nerve transfer may show even better results up to 100%. For shoulder external rotation, the nerve grafting and nerve transfers have equivalent result, and same is for shoulder abduction. Now, the main difference is that from the study of literature is that there is a lot of heterogeneity of data because there are different donors, different age groups. Grafts are sometimes direct grafting versus there has been the length of the graft sometimes has not been measured in the papers. And the amount of secondary surgeries and secondary procedures that is done is also sometimes not clear. So that makes the comparison of these two surgical groups slightly difficult. So my personal experience is not very big. It's about 41 cases. Majority of them, as in literature, has been herbs and extended herbs. We have usually performed the need for secondary procedures has mainly been giving Botox injections. We also have had contracture release performed in 2 of these patients. Now, one of the most difficult challenges which I face is to actually obtain a consent for a contralateral C7, where we actually have to at least talk about some theoretical disadvantage to the donor side, and which the parents are almost never willing to accept. There are also a lot of social reservations when we recommend surgery at the age of 2 months and 3 months in children with avulsion injuries. But avulsion injuries, as I've told you, the sooner we do it, the better in terms of outcomes. So my take-home message is, first of all, is the terminology. Avoid using the word obstetric, use the word neonatal. Herbs and herbs plus are the most common. Avulsion of all 5 roots, fortunately, is rare. Avulsion of the lower roots alone is more common. 70% of patients will recover eventually by following the cookie test and the towel test. Only 30% of them will require intervention. Nerve grafting and nerve transfers almost have similar outcomes. The main thing in neonatal brachial plexus injury is to prioritize hand function over shoulder function, and then finally over hand function, and then elbow function, and then shoulder function. Children have better plasticity and therefore have better outcomes. CIMT, electrical stimulation, passive range of movement, physiotherapy is extremely important. And the role of secondary surgeries should not be minimized, because they are extremely important to gain very, very useful overall limb function. Thank you. Thank you very much. I'd just like to thank my teacher, Professor Rajiv Midna, and acknowledge his teachings. Thank you.
It was a wonderful talk, Dr. Chandan. Now, because we are running short of time, I welcome Dr. Rajiv Sharma to his opinion regarding this peripheral nerve injuries and brachial plexus injuries. Dr. Rajiv Sharma.
Sir, Very nicely, all the four speakers have covered the topics assigned to them very, very nicely. The talk by Dr. Surya was very much informative regarding the clinical examination, followed by talk by Dr. Amit Thapa. And Dr. Sumit Sinha has covered all the aspects of management of brachial plexus injuries. And Dr. Chandan had the special focus on management of neonatal or birth brachial plexus injuries. So very nice. Overall, we have covered the all brachial plexus injuries, all sort of possible details in this span of time, sir. Any questions? If we are there, we can take. There were some questions, it seems.
Yeah, sir, if
Jatin?
permitted, may I ask
Yeah.
one question? Actually, I have two questions. First is to Professor Sumit Sinha, sir. So suppose sometimes during the intraoperative exploration, we find that the target nerve is stimulatable, like suprascapular is stimulable. So you still go with the transfer or you abort the procedure then?
This is a very good question, and most often during the surgery we encounter such type of situations. So the answer depends upon certain variables actually in this particular type of situation. Suppose if a nerve is stimulable, so we have to assess in our clinical examination before the surgery as to what is the range of function that this injured nerve is offering to the patient. Now, suppose if a nerve is stimulable, this does not mean that it will carry on useful function to the muscle. And a useful function is more than grade 3 power. So if I find that the patient has 2 by 5 power or 1 by 5 power and I get a stimulation unexpectedly during the surgery, I decide to go ahead with the nerve transfer and use it as a recipient. Number two, it also depends upon the time since injury has elapsed. So if suppose this stimulation and marginal muscle function is coming at around some 6 to 8 months after the injury, it's useless to keep this nerve. So in all probabilities, I will utilize this nerve as a recipient.
So
Sir,
I'll just add to what sir is saying. That the very important point is that pre-operative clinical evaluation is most important. I think intraoperatively, whatever it shows doesn't really make much of a difference because we have to differentiate between useful function and not very useful function. If you feel for some reason that the muscle is contracting even when you are stimulating near, say, just near the foramen, and still the muscle is getting stimulated, you can see visible, say, supraspinatus or infraspinatus muscle contraction. Then what I suggest to do is to perform what we called as a end to side repair. So instead of completely cutting the suprascapular nerve, you make a epineural window in the suprascapular nerve and then anastomose it to spinal accessory. So you allow some amount of spontaneous regeneration to occur, but you have basically kind of supercharged it with a transfer also.
Agreed. Perfect.
Thank you, sir. Thank you.
There is one
for
question.
the sake of information to the delegates, there was some question regarding the post-op rehabilitation and physiotherapy. Dr. Sumit, would you like to say something regarding this?
Yes, there was a question I answered on the chat box as
Yeah, you had answered in the,
time,
I think all the delegates should know about this.
how much time after which the physiotherapy to be started. So, I mean, it depends on what type of surgical procedure are you starting the physiotherapy for. If for a neurolysis, then immediately I start because there is no anastomosis involved in that. If you have done an anastomosis, then you need to protect that anastomosis to a certain period of time so that it does not break from because of the result of the movements in the physiotherapy session. So if I do an anastomosis, then I generally wait for 2 to 3 weeks after my surgery to start the physiotherapy. And physiotherapy is a very, very important thing, as I already stressed, we all stressed about, and minimum of about 4 hours or 6 hours per day of physiotherapy sessions. In fact, I encourage my patients to make gyms in their home so that they always keep on exercising. Number one, not only is this physiotherapy, but there is also a feedback electrical stimulation to the involved muscle, which is very, very a significantly helpful contributor to regain the static tone of the muscle, which is very important. So this is a low Faraday stimulation of the muscle, and this is a very cheaply available device which the patient can get from the market of the cost around some $2,000 or so, and it is it's strongly recommended that you prescribe this to your patients to buy this and keep on stimulating almost on a daily basis the muscles of the injured limb.
Thank you, sir. Over to Dr. Kodeshwaran for further comments and
It was a wonderful knowledge sharing session, which was now taken up by most of the younger colleagues because of its complexity. So, as a experienced team like Sumit and other ISPNS team should motivate the younger colleagues, and they should guide how to take this specialty in course of time, and also it should be spread all over the country because most of the areas of our country doesn't have these services. Maybe most of few institutes are catering these kind of uh, procedures. So I request Dr. Sumit to take over this as a mission and should motivate a lot of younger colleagues to take this subspecialty as neurosurgical subspecialty. It was a wonderful meeting, which was very complex and also it was very impressive and knowledge sharing. So I thank all speakers and panelists, especially Dr. Jitin, who arranged this meeting within a very short span of time. So on behalf of NSI, thank you everyone for joining. Thank you all.
Thank
thank
you.
you, sir. On behalf of ISPNS, we thank everyone and especially you, sir, for giving the iSpace an opportunity to share the platform with NSI, sir. Thank you so much, sir.
Thank you. Thank you, everyone. Bye-bye.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you, everyone. Bye-bye.